If you want to learn everything that you need to know about dermatology for the USMLE, then you have came to the right place. So let's begin. Diseases that cause a rash on the palms and soles is an extremely high topic for the USMLE. One such disease is Rocky Mountain Spotty Fever. We can remember the other causes of rash on palms and soles with this trick. Well, it's more like tricks. So here's a mnemonic. T, toxic shock syndrome. R, Rocky Mountain spotted fever. I, infective endocarditis. C, Coxsackie A. K, Kawasaki. And the first S, staph scalded skin syndrome. And the last S, secondary syphilis. Recall that in infective endocarditis, these patients can have Janeway lesions on their palms. For Coxsackie A, I want you to leave in the comment section below what disease an infection with the Coxsackie A virus can lead to. But to be honest, all of these diseases here are extremely high yield. You can probably think about them like the tricks that the USMLE have. But let's go. Here we have two pictures showing erysipelas and cellulitis. Do you know which is which? If not, then that's totally fine. That's why I'm here. Or better yet, that's why you're here watching this video. So the first picture shows cellulitis, and the second picture shows erysipelas. Erysipelas and cellulitis can present similarly, and of course, anything with overlapping features or that are really the same, examiners love to test them because you can confuse them. However, I'm going to show you how not to do that. So for erysipelas, if you take a good look at this picture, you can see that it has raised, sharp borders and a very intense erythema. While that is not the case in cellulitis. In cellulitis, the borders are indistinct, the erythema is not as intense, and the borders are not sharp. It's important to know that cellulitis is a skin infection of the deep dermis and subcutaneous fat. However, erysipelas is more of a superficial skin disorder. Now let's look at an image so that you can remember this fact. So how I remember it is with this image of the Earth's core, right? So the C from cellulitis and the C for core. So it lets me know that just like with the Earth's core, it's very deep, and cellulitis is deep as well. And for erysipelas, it is the opposite. So I hope that this image will help you as much as it has helped me. Now here we have erythema nodosum and erythema multiforme. Erythema nodosum is a delayed hypersensitivity reaction. It's usually tender erythematous nodules, most often on the shins, as you can see in this picture. However, in erythema multiforme, we describe these lesions as being target lesions. However, the high yield fact is that these two skin conditions have very high yield associations. Let's take a look at what they are. Erythema nodosum is associated with inflammatory bowel disease, sarcoidosis, penicillins, sulfonamides, and even oral contraceptives. However, erythema multiforme is associated with herpes simplex virus, extremely high yield. So basically anything that you see in green during this entire video, just think of it as green, it's money. It's money for the USMLE. So know it well. Now I can probably bet that absolutely everyone has seen this picture. So let's review this topic. This picture is showing erythema chronicum migrans, and this is the key dermatological finding in Lyme disease. So remember this very high yield fact. Lyme disease is treated with amoxicillin in patients less than 8 years old. However, doxycycline is used in patients older than 8 years old. Recall that doxycycline is a tetracycline and they can cause teeth discoloration. So that's the reason why amoxicillin is given in patients less than 8 years old. However, there is another extremely high yield fact about tetracyclines. So let's say we have a patient, she has Lyme disease, she was given doxycycline for her treatment, she's fine. One day she goes for a walk or a run, and then she is very, very sunburnt. Why is that? Well, it's because tetracyclines can cause photosensitivity. We can remember the drugs that can cause photosensitivity with the mnemonic SAT for a photo. SAT stands for sulfonamides, amitriptyline, and tetracyclines. So I know we just talked about a patient being sunburned, but this picture on the other hand is definitely not a sunburn. This is red man syndrome. So how we can differentiate between a sunburn and red man syndrome is of course the patient's history, what drugs they took because different drugs cause different reactions, and in sunburnt patients, they usually have a tan line, but that's not seen in red man syndrome. So the drugs that most commonly cause red man syndrome are vancomycin and ciprofloxacin. If you made it this far into the video and you are enjoying this extremely high yield content, be sure to power up that like button and hit subscribe. Now here we have 3 high yield skin findings: Porphyria cutanea tarda, Lichen planus, and cryoglobulinemic vasculitis. But my question for you is, what disease are all these different skin conditions associated with? If you said hepatitis C, then you are correct. So it's very important that if you see any of these skin findings, you have to screen for hepatitis C, especially if that patient has a history of IV drug use. So porphyrias are disorders of heme synthesis, but the most common one is Porphyria cutanea tarda, and it can be triggered by the ingestion of estrogens or ethanol, and of course it's associated with hepatitis C. These patients may have fragile skin, photosensitivity, and even blisters. Lab work can reveal elevated plasma or urinary porphyrin levels. And in order to treat porphyrias, we use phlebotomy or hydroxychloroquine. Now let's focus a bit on lichen planus. So that includes the 5 P's: purple, pruritic, polygonal, papules, or plaques. There's also drug-induced lichen planus that's associated with a number of drugs, some of them being ACE inhibitors, thiazides, beta blockers, or hydroxychloroquine. Now here we have a classic image of herpes zoster. This is a painful reactivation of the varicella zoster virus, and it causes a vesicular rash in a dermatomal distribution. That is extremely, extremely high yield. So in order for us to decrease the duration of the disease or the incidence of post-herpetic neuralgia, we give the patient acyclovir. 2 of the biggest predisposing factors for shingles include the patient's age and if they are immunocompromised. And now we have that classic rash seen in Henoch-Schönlein purpura. So this is typically seen on the buttocks or thighs of children who have Henoch-Schönlein purpura. So we can remember some of the key features of this disorder with the letters HSP. H, hematuria. S, small child, like small children are usually affected. And P, palpable purpura. If you want to see a high-yield review of Henoch-Schönlein purpura, IgA nephropathy, and post-strep glomerulonephritis, be sure to check out the link in the description below. Patients with celiac disease can develop this skin finding called Dermatitis herpetiformis. Dermatitis herpetiformis is an autoimmune reaction due to the ingestion of gluten. In order to treat this, the first line is, of course, a gluten-free diet. However, if that doesn't work, then we have to use dapsone. But let's say a patient takes dapsone, but then they develop hyperbilirubinemia and jaundice. What is the most likely cause of that? And that is a dapsone-induced hemolytic anemia. This occurs in patients who have G6PD deficiency. Guys, if you like the high yield facts, be sure to power up that like button, smash that like button, make that like button turn blue, and of course, subscribe to the channel. Now let's continue. Now this is Tinea versicolor. So you will see a question that says, there is this young woman, she went sunbathing or went to the beach, but after that she noticed these hypopigmented macules. That is classic presentation of Tinea versicolor. That's why I have this little image here of someone like sunbathing or just relaxing in the sun. So Tinea versicolor is a superficial fungal skin infection. If you look under microscopy of like skin scrapings of patients with this disorder, you'll notice something called spaghetti and meatballs appearance. And in order to treat these patients, we use topical selenium sulfide, ketoconazole, or terbinafine. HIV also increases the risk of Tinea versicolor. So HIV is very, very, very prominent in dermatology and especially in this lecture as it pertains to the USMLE. A lot of cases you will hear something like, hey, this person has a very diffuse skin condition. More likely it has an association with HIV, or HIV would increase the likelihood of developing said skin condition. So just keep that in mind. And let's move on. Pityriasis rosea. So this usually starts with something called the herald patch, and that is what that arrow is highlighting. After the development of the herald patch, you can see development of clusters of small oval-like lesions, and they are oriented in a Christmas tree. That's why you see that lovely Christmas tree right there. So you can remember this association. However, before the patients develop any skin findings, they can have a viral prodrome. So they kind of feel sick, like maybe have like a fever, runny nose, or something like that. And in order for us to treat these patients, we of course provide them with reassurance. And also because pityriasis rosea can be very, very itchy, we can give them antihistamines or some topical steroids to relieve that. And here we have vitiligo, which is an autoimmune disease that occurs due to melanocyte destruction. And that results in a depigmentation. So it's considered as a depigmentation disorder. It's very important that you remember that it is an autoimmune disorder because that means it can be associated with other autoimmune disorders like type 1 diabetes, Hashimoto's thyroiditis, or alopecia areata. So yeah, just keep that in mind. Very, very high yield. Let's move on. So for vitiligo, we're kind of used to seeing the typical image like I showed you before. However, there is a subset of vitiligo that can only affect the genital or oral mucosa. And this picture is showing you an example of the oral type of vitiligo. Now here we see some hypopigmented macules, also known as ash leaf spots. And these can be present at birth and are most common on the lower extremities and on the trunk. But my question for you is, what condition is this associated with? So you don't forget, I've asked you 2 questions so far. The first one being, what disease or condition can infection with the Coxsackie-A virus lead to? And what condition is the ash leaf spots associated with? Be sure to comment them down below and let me know. Lichen simplex chronicus. This is a neurodermatitis. So it has the features of thickened excoriated plaques, and this is caused by persistent itching and rubbing. It's very high yield that it's associated with anxiety disorders. So it typically occurs in areas that are very easy to reach. This is Hidradenitis suppurativa, and it's probably a very mild version of what you may see in practice questions or on exam day, because this condition can lead to sinus tract formation or even scarring as well. It typically arises in places where there are folds or creases like the axilla or the inguinal area. And this occurs due to an occlusion or inflammation of the folliculopilosebaceous units. Very high yield, remember that. The risk factors include a history of smoking, diabetes mellitus, chronic mechanical stress of the skin, such as excessive friction or pressure, and obesity. So, one of the treatment options for hidradenitis suppurativa is weight loss. Now, this candidal infection also occurs in the folds as well, and it is usually moist and macerated. Okay, now on to scabies. So patients that have scabies, it is very, very, very itchy. And it's characterized by like these red papules and burrows, and you can see them in the axillae, the genitalia. But of course, the classic thing that we're used to is the interdigital web spaces. And it is also a type 4 hypersensitivity reaction to mite, feces, and eggs. So the first line treatment for this is permethrin or oral ivermectin. You also need to be sure to clean bedding and clothing or place them in a bag for like more than 3 days because the mice can survive up to that long. And now we have the USMLE's favorite Tineas, Tinea capitis, Tinea corporis, and Tinea pedis. These are very common and very classic pictures, so be sure to look at them and know them well. A key thing to remember about all of these conditions is that they are all treated with topical antifungals, except Tinea capitis that is usually treated with oral griseofulvin. So, in the pediatric population, these two conditions can be easily confused, but here's a simplified way so that you can remember them. So in Candida diaper dermatitis, the skin folds are involved. That's because Candida does not care. They don't obey any boundaries. They go wherever they want to go. So the skin folds are involved. However, for irritant diaper dermatitis, the skin folds are not involved. In order to treat Candida diaper dermatitis, of course, we use antifungals, while we use barrier ointments for the treatment of irritant diaper dermatitis. And let's stick with the pediatric population a bit more and look at these two conditions: congenital dermal melanocytosis and congenital melanocytic nevus. I put them side to side because they both have congenital and a melano something, so they can be kind of confused. So I put them here to highlight the differences with their names, and you have visual representation so you don't confuse them. But you may know congenital dermal melanocytosis more commonly as Mongolian spots. Mongolian spots are commonly found in African, Asian, and Hispanic infants, and they look like blue-gray macules, and they're more common on the sacrum and the buttocks. So sometimes you have a case or a question where, the parent comes in, they're like, they have this rash, they're freaking out. You have to know that no treatment is required because it's self-limiting and it goes away. Or you might have a question and in the option, they're like, called Child Protective Services, and it's basically trying to steer you towards thinking that it's a case of child abuse. So it's very important to look at this picture and know it well. Mongolian spots or congenital dermal melanocytosis. However, for the congenital nevus, it's hyperpigmented patches with a very, very dense patch of hair follicles as well. Alopecia areata is another autoimmune condition, just like vitiligo that we talked about before. So, of course, it can be associated with other autoimmune diseases. So, it's characterized by a painless, patchy hair loss. There's no erythema, no scarring, and no scaling. In order to treat alopecia areata, we can use topical or intralesional steroids. Okay, now here we have acanthosis nigricans. This is described as a hyperpigmented or velvety plaques on the axilla, neck, or groin. It's extremely high yield that it's associated with insulin resistance states, like the ones mentioned here, diabetes mellitus or PCOS. However, in older patients, if you see acanthosis nigricans in older patients, it can be associated with a GI malignancy. And here we have pseudofolliculitis. This is most common in Black men. And if you just look at this picture and know it's an easy gimme question. So pseudofolliculitis, more common in Black men. And the treatment for this is usually to stop shaving or use a different shaving technique. Now, this slide is so high yield. So let's master this. So this is psoriasis. Psoriasis has different dermal presentations. They typically have the silvery plaques on like extensor surfaces. They can also have nail pitting, as you can see with the green arrow, or even eye changes such as conjunctivitis or uveitis, represented by the red arrow. Now, this phenomenon here, that's basically the worsening of psoriasis when there is local skin trauma. So even if like with intense itching, it can cause that type of reaction. One way that examiners can test you is by saying, oh, this patient has the silvery plaques. What other clinical findings can be present in the patient? And you have to know all these other findings. So if you know them, then that can be a quick and easy question. The treatment options for psoriasis is also interesting because this includes topical high-potency steroids or vitamin D derivatives. But if the psoriasis is more severe, then we have to move on to systemic treatment such as methotrexate. So the third time is a charm. So please be sure to like this video so that I know you're enjoying the content that I'm creating. Now, in this picture, we're seeing all these different conditions on cheeks. Basically, cheek conditions. So what are they? Well, let's look at the top two conditions first. And these are rosacea and SLE. So it's very important that you look at these pictures and realize how they are different. The key finding is in that SLE, you have sparing of the nasolabial folds. However, in this type of rosacea, the nasolabial folds are involved. So that's a high yield way of distinguishing them. And this is melasma. So this is typically described as a hyperpigmentation on the cheeks, and it's associated with states with elevated estrogen, like in patients that take birth control or in women that are pregnant. So they can describe it as like a pregnancy mask and like, oh my gosh, what should we do to treat this patient? So if that patient is pregnant and they have this quote unquote mask, then we just have to wait until the mother gives birth, and then it can go away after that. And this picture here is showing erythema infectiosum. So my third question for you, is what virus can cause this skin finding? Leave it in the comments below. This is the last question, I think. So just 1, 2, 3. Let me know what the answers are for all the questions that I asked. And now on to our favorite gimme question, which is impetigo. So if we see this picture or hear the classic description of honey-crusted lesions around the mouth or a honey-crusted rash, then we automatically think about impetigo. And impetigo can lead to post-strep glomerulonephritis. And again, if you want to see a high-yield video comparing post-strep glomerulonephritis, IgA nephropathy, and Henoch-Schönlein purpura, be sure to check the description of this video. Okay, now here we have a dermatofibroma, which is a non-tender nodule. What's very high yield is that if you pinch this nodule or this dermatofibroma, it can cause a dimple, as you can see here in this red circle. Okay, so molluscum contagiosum. This is caused by the pox virus. If patients have this, but it is very widespread, then what we have to do is an HIV test. And this picture right here is pyoderma gangrenosum. It's characterized as a rapidly progressive, painful ulcer. And of course, you can see the purulent base. It's most commonly associated with inflammatory bowel disease. So if you have a question where you see this picture or there's a description of pyoderma gangrenosum and they ask you the next best step, if you see colonoscopy, choose that as the answer. And here we have livedo reticularis that has a mottled vascular pattern, and it's described as being like a lacy pattern or a net-like pattern. And here we have acne. So in mild acne, we can use topical retinoids. If that doesn't work, we can add a topical antimicrobial. For moderate acne, we can use oral antibiotics. And for very severe acne, we can use isotretinoin. So it's basically like a step up, like from topical retinoids to topical antimicrobials to oral, then to isotretinoin. So what's high yield about this topic of acne is the isotretinoin. So you'd have a patient come in and she wants to start this medication or she is on this medication. They're basically seeing if you know the protocol, which basically involves having 2 forms of contraception and doing regular pregnancy tests. So if a patient comes in and they have very bad acne, you're doing all the steps and it's just not going away, one thing for you to consider is a steroid-induced acne. So for steroid-induced acne, it does not respond to regular acne treatment. The best treatment for these patients include stopping the steroid. And now here we have the skin findings of dermatomyositis. So these skin findings include Gaucher's papules, as you can see on the dorsum of her hands right there, or a heliotrope rash, which is seen on the eyelids, and the last one is the shawl sign. It's important to note that dermatomyositis can be associated with polymyositis, where these patients have a weakness of proximal muscles, like the muscles of the hip girdle or shoulder. Here are the 3 main types of dermatitis tested on the USMLE. Do you know which is which? If not, let's go to the next slide. So let's focus on seborrheic dermatitis first. So how I identify that one is because of the greasy appearance, and it's usually the crater cap seen in infants or neonates. While for contact dermatitis, it has vesicles in the exposed area of the skin where they were exposed to the irritant. For atopic dermatitis, it's not so cut and dry, so I basically just identify that one as like a process of elimination. Now, you might be wondering why those check marks and X's are there. Well, that's because I'm trying to highlight that atopic dermatitis and contact dermatitis are treated with topical emollients, while seborrheic dermatitis is not treated with topical emollients. It is treated with selenium sulfide shampoo, just like with Tinea versicolor. It's very high yield that you know that seborrheic dermatitis has associations with HIV and Parkinson's. And here we have keratosis pilaris. So this is more common on the posterior forearm and is described as a roughened texture of the skin. So we usually treat it with keratinolytics like salicylic acid. Keratocanthoma. So this is a nodule with a keratin plug in the center of it. Okay, now this is so high yield. Here we see pictures of a patient with lymphedema who then goes on to develop angiosarcoma. Recall that we can see chronic lymphedema in breast cancer survivors. However, these patients can then go on to develop angiosarcoma, which is a malignant tumor. It's derived from the lining of blood vessels and lymphatics. The strongest risk factor for the development of angiosarcoma is localized radiation therapy. Guys, you're like 30 minutes into this video, so might as well you just smash the like button, power it up, make it turn blue so that I know you're enjoying this content. Now let's continue. So we are going to talk about skin cancer. The number one risk factor for skin cancer is accumulated exposure to the sun. So of course we have to talk about sun protection. Avoiding the sun is the best form of photoprotection. But if you do go outside, it's recommended that you use sunscreen with at least 30 SPF or greater, and you apply that 15 to 30 minutes prior to going outside. However, you have to reapply the sunscreen every 2 hours, and if you go swimming, you have to reapply it immediately after you swim. Dark colors, long sleeves, and broad brim hats, like in this picture, are recommended to block sun exposure. Now here we have a picture of a melanoma. Let's say we have a patient that has moles, but there's this one mole that just does not look right, and we call it the ugly duckling sign. If you see a patient with moles, but there's one that just looks very different, it bleeds, it itches, then we should be very suspicious of a melanoma. Other features that are suggestive of a melanoma can be remembered with A, B, C, D, E: asymmetry, border irregularities, color variation, diameter greater than 6 millimeters, and evolution in shape, size, or color. So if a lesion has any one of these, then we have to do an excisional biopsy. So there are three main subtypes of melanomas. The nodular type has the worst prognosis. The acral type is more common in African Americans. Also, melanomas are usually commonly associated with what's called the Breslow's depth. However, that has changed to the AJCC depth, but I'm not sure if that is being reflected in the USMLE exams currently. So just be aware of those depths, the Breslow depth and the AJCC depth. It basically lets you know the prognosis of the melanoma. So, basal cell carcinoma, that is the most common skin cancer in the general population. Basal cell carcinoma can have this pearly-like appearance, and it's very important that if basal cell carcinoma is on more delicate or sensitive areas such as the face, to excise this or remove this lesion, we use the Moss surgery. So that's basically where thin layers are removed, and that is the procedure that is preferred for very delicate, sensitive areas. Squamous cell carcinoma, on the other hand, that looks a bit different as you can see here. It can arise in chronically scarred, inflamed, or wounded skin. So if a squamous cell carcinoma arises from a burn, this is called a Marjolain's ulcer. If a squamous cell carcinoma is biopsied, then we may hear a description of keratin pearls. Okay, so this lovely picture right here, this is showing you which cancer affects which part of the lip. So squamous cell carcinoma most commonly affects the lower lip, while basal cell carcinoma affects the upper lip more commonly. I remember this by using BS. So B for the upper lip and S for the lower lip. And here we have seborrheic keratosis. So this is described as having a stuck-on appearance. It's very important that if you see a patient with many of these, then this can be indicative of a GI malignancy. A Nikolsky sign is when there is a light pressure or friction of the skin, and that leads to the upper or more superficial layer of the skin to slip off. So that is a Nikolsky sign. This is positive in patients with Stevens-Johnson syndrome or TEN. These conditions are precipitated by the use of drugs. So we can distinguish them by the percent of body surface that's affected. So less than 10%, that's Stevens-Johnson syndrome. 10 to 30%, that's a mix. And greater than 30%, that is TEN. It's very important to note that these patients require aggressive fluid support and wound care in their management. And here we have staph scalded skin syndrome. Recall that this was part of the tricks mnemonic in the beginning of this video. In this syndrome, these patients also have a positive Nikolsky sign. It's important that you know it's commonly seen in the pediatric population and is usually preceded by some sort of infection. Finally, we have pemphigus vulgaris and bullous pemphigoid. Pemphigus vulgaris is characterized by flaccid bullae and the mucosa is involved. However, for bullous pemphigoid, the bullae are tense and the mucosa is not involved. So pemphigus vulgaris and bullous pemphigoid are so high yield because they have overlapping features and they can be easily confused. That's why I have this table here to basically compare the main points that examiners love to test. How I remember some key features is that pemphigus vulgaris starts with P. So pemphigus has a positive Nikolsky sign and positive mucus involvement. While for bullous pemphigoid, it is the opposite. But that brings us to the end of our very high yield dermatology review. This video has everything that you need to know for your exam. If you have any questions, be sure to leave them in the comments below. And if you have made it to the end of this video, thank you so much. This is like my third attempt at making this because I just wanted to make sure it had all the content that you need for your exam. I just think it's so important that we have a resource that is free and a resource that is high yield. Medical education is so expensive, so this is just me doing my part and just trying to help. So I really hope that you enjoyed this video. In order to let me know that you did, be sure to power up the like button, hit subscribe, and that notification bell. Thank you so much. And to continue learning more, be sure to click this video right here. Thank you so much. Goodbye.